Welcome to the debate. Today we're focusing on one of the most significant pharmaceutical advancements in decades, GLP-1 receptor agonists. We're talking about the class of medications including semaglutide and tirzepatide, which you probably know as Wegovy and Zepbound. These drugs have shown, well, transformative efficacy, really moving far beyond just treating type 2 diabetes to fundamentally redefining how we treat obesity and cardiovascular risk.
And then that efficacy it's undisputed. However, these powerful agents also come with very substantial, clinically relevant safety concerns. We're dealing with medications that carry a significant burden of adverse events and, frankly, a long list of serious warnings and precautions.
Right. And that tension between this monumental benefit and the serious risk brings us to our central question today. Should the demonstrated powerful clinical benefits, especially that robust cardiovascular and weight loss efficacy, encourage broader, more permissive prescription for the millions who meet the criteria?
Or, conversely, do the frequent and often quite bothersome adverse events and the specific long-term risks, do they necessitate a highly restrictive, very cautious approach, limiting use only to strictly defined patient populations where that risk-benefit calculation is just overwhelmingly positive? My position is the latter. The risks demand rigorous caution and a much more limited application.
See, I disagree fundamentally with this idea of restriction where there's a clear clinical need and a demonstrated benefit. I'm going to argue that the profound clinical benefits, particularly the measured cardiovascular risk reduction, decisively outweigh the known, manageable side effects for the appropriate candidates. The evidence we have isn't just additive, it's paradigm shifting. Okay, so for me, the cornerstone of this perspective really lies in the outcomes of the SELECT trial. This data gave us definitive evidence that semaglutide in adults with established cardiovascular disease and obesity achieved something unprecedented. It significantly reduced the risk of major adverse cardiovascular events, or MACE, that's, cardiovascular death, non-fatal heart attack, or non-fatal stroke, by a full 20%. That gives us a hazard ratio of 0.80. This is not some secondary benefit derived from weight loss. This is primary systemic protection. We're talking about reducing the single biggest killer globally.
The MACE reduction is monumental. Yes, I absolutely agree. And it changes the clinical calculus entirely. However, we have to ground this benefit against the reality of chronic treatment. To realize that 20% benefit, the patient has to adhere to the treatment for years, probably indefinitely. And this is where the safety profile presents a major barrier. These medications cause a high rate of discontinuation due to adverse reactions.
I know the high discontinuation rate, 16.6% in the treatment arm versus about 8.2% on placebo, mostly due to GI symptoms, gets cited often. But what we're asking patients to do is compare short-term discomfort, which often wanes after you titrate the dose, against a lifelong systemic protection from a heart attack or a stroke.
I think it's a bit reductive to call these short-term discomforts. The challenge isn't only the frequency, but the potential severity of these events. Beyond the nausea and vomiting that drive people to stop taking the drug, the list of serious warnings is comprehensive. Acute pancreatitis, acute gallbladder disease like cholelithiasis, and critically, acute kidney injury. We also have to deal with the complex safety management needed for specific groups, like the heightened risk of diabetic retinopathy complications in patients with type 2 diabetes.
But focusing purely on efficacy for a moment, we can't overlook the magnitude of the weight loss itself, which is so clinically meaningful for reducing long-term morbidity. We see robust efficacy in adults and established effectiveness now in pediatric patients, kids aged 12 and older with obesity. We're discussing an average of nearly 15% weight reduction with semaglutide over 68 weeks. Tirzepatide trials showed even higher results, up to a 24.3% mean change from baseline. Plus the whole cascade of improvements that comes with that. It's key. Lower triglycerides, better LDL profiles, improved blood pressure. It's a total metabolic health overhaul.
I respect the metabolic improvements, I do, but the sheer number of documented severe risks and, frankly, critical unknowns necessitates a brake on the enthusiasm for broad use. Animal studies revealed an unknown risk of thyroid C-cell tumors, including medullary thyroid carcinoma, MTC, in humans. This means you need rigorous screening, a personal or family history of MTC or multiple endocrine neoplasm syndrome type 2. Those are absolute contraindications. My argument is that if the patient population is so complex that a standard prescription requires immediately excluding multiple groups, you can't consider it a broad access medication without significant caution.
Well, that brings us directly to the first core trade-off here, the balance between that profound efficacy and the gastrointestinal tolerability. While you rightly emphasize adverse reactions like nausea, diarrhea, and vomiting, my perspective is that these most common issues are specifically addressed and minimized by the slow, structured dose escalation schedule. We start at very low doses, we increase gradually. The long-term proven benefit for major cardiovascular events absolutely justifies managing these transient, short-term GI effects.
I'm sorry, but I just don't buy that the dose escalation is enough mitigation when you look at the clinical consequences. While titration helps some people, sure, the evidence still shows severe gastrointestinal events happening at roughly twice the rate of placebo. More importantly, we have to talk about the mechanism behind these seemingly minor symptoms. This drug works by slowing gastric emptying. That is its mechanism of action. So when a patient experiences severe nausea or vomiting or diarrhea, that delayed gastric emptying fundamentally hinders their ability to adequately rehydrate.
I see where you're going. Volume depletion.
Exactly. That severe, rapid volume depletion is the proximate cause of acute kidney injury or the worsening of existing renal failure. We've seen this in post-marketing reports leading to hemodialysis. This shifts the GI discomfort from being a tolerable inconvenience to a critical safety hazard. It's not just a patient being bad at managing their fluids. It's a drug mechanism creating a situation where the patient is acutely vulnerable to a rapid renal crisis. That high bar for constant critical monitoring is simply not feasible for a medication prescribed widely across every primary care setting.
That's a compelling point about the cascade effect, but doesn't that risk just reinforce the need for meticulous patient selection and education rather than wholesale restriction? If we identify patients at higher renal risk or those who already struggle with adherence, we proceed with caution, but we shouldn't restrict access for the majority of otherwise healthy, high-risk individuals who stand again that 20% MACE reduction.
But how realistic is it to rely solely on patient education to mitigate a life-threatening complication like AKI? And we have to be aggressive in defining the unsuitable candidate. We mentioned MTC, MEN2, hypersensitivity, but that's just the start. The American Society of Anesthesiologists had to issue guidance recommending stopping these drugs before planned surgeries.
Right, for general anesthesia.
Yes. Why? Because that delayed gastric emptying dramatically increases the risk of pulmonary aspiration during induction. This isn't a simple accommodation. This is a safety measure that might require a 2-month drug holiday before an elective surgery. That impacts the patient's health and introduces a complex monitoring requirement that broad use makes much harder to manage.
I would argue that's a procedural inconvenience, not a permanent disqualification from life-saving therapy. The vast enduring benefit of reducing heart attacks and strokes has to be weighed against a predictable, temporary stop before a planned procedure. I'm just not convinced that these hurdles should limit access for the large population who can benefit. And that population includes pediatric patients, kids 12 and older, where we've established safety and effectiveness.
But when we talk about pediatric use, we enter a long-term risk horizon that requires even more scrutiny. Are we prepared for lifelong follow-up to rule out the human relevance of that MTC risk? And what about subpopulations? Have you considered the exploratory safety analysis from SELECT? It shows new, disproportionate risks that make appropriate candidacy much, much narrower.
You're referring to the numerical imbalances in specific fracture serious adverse events.
Precisely. We know weight loss, especially rapid weight loss, is associated with a drop in bone mineral density. But the data showed that this specific serious adverse event, fractures of the hip, femur, and pelvis, appeared more frequently in women and in patients aged 75 and older. For patients over 75, the hip fracture rate was numerically higher. It was 1.28% on semaglutide versus 0.6% on placebo.
Well, while that imbalance warrants caution and more study, rapid weight loss itself is the likely driver. That risk exists across all successful obesity treatments.
But the drug accelerates the rate and magnitude of that weight loss far beyond standard interventions. The fact that the signal is concentrated in these specific high-risk groups suggests we cannot treat this as a standard weight loss drug. It implies that an appropriate elderly candidate needs baseline bone scans, maybe prophylactic measures like vitamin D or even osteoporosis medication. That adds a huge layer of complexity and cost. Are we really equipped for broad use when the screening for elderly women has to include skeletal monitoring?
That relies on a perfect clinical scenario that rarely exists. Clinical practice is about managing risk, not eliminating it. We have clear, long-term evidence of profound cardiovascular risk reduction. This is a monumental finding. The benefits even extend beyond MACE to include fewer composite nephropathy events driven by fewer persistent macroalbuminuria events.
I come at it from a different way. While the primary endpoint is positive, we have to stay intellectually cautious about the entire long-term profile, especially the risks that are not driven solely by weight loss. Acute gallbladder disease, for instance, occurred more frequently in the semaglutide group than placebo, even after they adjusted for the degree of weight loss. That strongly suggests a direct drug effect on the gallbladder.
But the difference in incidence is measurable, but, it's relatively small, 2.79% versus 2.31% for gallbladder-related disorders. It doesn't nullify the 20% MACE reduction. It's a known risk, and it's monitored.
But it illustrates the complexity of the drug's systemic impact. And when you combine that specific gallbladder risk, the persistent unknown about the thyroid C-cell tumor risk, and the mandatory counseling about symptoms like a lump in your neck, you create a profile of high alert maintenance. The patient has to become a partner in this rigorous ongoing vigilance, which you just can't assume in a broad access model.
I think we have to avoid letting theoretical or manageable risks overshadow proven mortality reduction. For people with established CV disease, this medication fundamentally reduces the progression of both cardiac and renal disease. Restricting access to a treatment that prevents cardiovascular death because of manageable GI symptoms or specific known contraindications would be, I think, a public health disservice.
And I would counter that minimizing the GI risk as merely manageable misunderstands the clinical gravity of the AKI risk. Are you suggesting we sideline an entire patient population, the elderly, from rigorous skeletal monitoring just to enable broader prescribing of a drug that carries specific fracture risk in that very group? The sheer complexity demands careful, expert assessment for every single patient.
Our discussion today really underscores that these GLP-1 RAs offer proven, profound benefits, most critically, that 20% reduction in MACE risk for adults with established cardiovascular disease. For candidates who meet the clear indication criteria and don't have contraindications, this is a necessary and highly effective long-term therapy that improves overall cardiometabolic health and, importantly, their mortality risk. The potential for population-level impact is just staggering.
We agree entirely on the significance of the efficacy data, but this exchange has illuminated the critical importance of meticulous patient selection and rigorous infrastructure. The potential for severe GI side effects cascading into life-threatening kidney injury, the specific fracture risks for the elderly and women, and the severe warnings on MTC and pancreatitis, it all means this powerful medication requires expert prescribing, continuous monitoring, and comprehensive patient counseling. It must never be treated as a simple, low-risk prescription.
We leave our listeners to weigh the clinical evidence for themselves, particularly that trade-off between a guaranteed powerful benefit against significant, complex, but often manageable risk.
Acknowledging that balancing that monumental benefit against the complex safety profile requires continuous clinical assessment and individual tailored judgment.